Join with the audio. So, so we are recording, and we're in day two, and this is what we're covering today: pediatric cardiac arrest, special needs patients, OB, Arkansas peds. So this is a peds day for you, and we'll be talking probably for 6 hours of peds, 1.5 hour special needs, and half an hour of OB. Now, the good part about this is some of these hours, like 2 hours of ped cardiac arrest, about an hour of that is supposed to be you doing CPR somewhere. So if you've got your CPR, American Heart Association CPR, you should be well to go with that. So, all right. And let me right quick do a little roll call so I can see who's all here. Jamie is here. She's on the phone. Greg is traveling. I see Cody Hudson. Cody, where'd you go, Cody? There you are. Say something to me, Cody, so I know you're there and you just hadn't called.
I'm here. Can you hear me?
I can hear you. That's it.
Okay, I'm in dispatch today, so if you call me and don't get me, I'm probably on a phone call or something.
All right. Well, if I ask you a question, you don't come in, please come back to me later and let me know that you heard me, because that's how I tell that you haven't called up, put the phone down, and walked off. Now,
I'll do that.
all right. So and David, I can see him, so he's got his camera on, so he's in good shape. All right. And Brian, he puts a piece of cardboard over his, so and I don't show mine that much. Hi, Jamie. So, all right. I need to do a screen capture of this. Hang on just a second, guys. There we go. Y'all may see this or you may not. I don't know. I'm really not sure about some of this, but I'm learning. Okay.
See the mouse. Oh.
I have a big mouse. Size is everything. All right, one person's waiting. Let's go get them in here. Let me close that. Golly, that's why it couldn't see it. Let me go get this next person in here. LaDonna, there you go. And it's telling me that I can't do that. That's all right. It's one of those days. I was so looking forward to seeing a little bit of snow, and I understand Searcy County did get snow. So there you go.
I had a little bit this morning up on the mountain, but it was already melting off by the time I came into work.
Oh, you didn't expect it to last, so but anyway,
I was hoping.
It's always good to see it this time of year. All right. Any questions on the 6-day breakdown? And these will all be on Thursday, so you can just kind of set your watches, clocks on that. I can get you a schedule out and publish it to everybody in EMS if that's what you'd like. So, all right. Greg, you be careful driving. I know you're on 412 over there, and that's not a safe road to be on. So, okay, stop share. I'm going to go back to looking for something else to share with y'all. As I said, this is, nope, that's what I want. Where's it at? It's over there. If you go to the NREMT website, you will receive a place out there where you'll go and you'll see something like, well, you'll see this. If you go down here to the paramedic gold patch and hit recertification, it'll go into all this NRP recertification, and it'll talk about national components and state components and local components. And that's how many hours you got to have, guys, for paramedics. 30 hours there, 15 and 15. But the good news is right down here, if you want to go and know where I'm at, this is the NCC guide. So this is the guide for paramedics that teaches and gives me an outline of what you're supposed to know. And the first thing we've already covered most of this ventilation stuff up here, and we're down now to pediatric cardiac arrest, which is something none of us want to have. And I'm going to bring that up for you guys looking on the monitors. Can y'all see that okay? Okay, good. So here are your objectives for today. Going to talk about ALS skills for pediatric patient airway management, vascular access, and some pharmacology. We're going to do some investigation of unique cases of pediatric cardiac arrest, and you should have demonstrated through education your techniques for 1 and 2 rescue, CPR, and current techniques for cardiac arrest management skills, and that would be your PALS. And I know all of you guys are PALS and AHA, Heart Association, Saver, Lifesaver, CPR. All right. So, right quick here, Mr. Bell,
Yes, sir.
pediatric cardiac arrest. What
Okay.
do you have you got one in your mind that really comes out and sticks out in your mind?
I've had several.
Okay. I'm not trying to get war stories going, but did you feel like you were adequate to handle that pediatric cardiac arrest?
Most of them, yeah. But there's always that difficult case or two.
Sure. And between bites, Jamie, if you would let us know, how do you feel when you go on a pediatric run?
I feel stressed out, but I feel that after multiple years of PALS and everything else and doing any kind of CUs, I think that we're well prepared. And, you know, I always keep that comfort level that, you know, there's other people on shift. I know that if I have questions, I can call. I know I can call med control, you know, so I think that we're okay.
Good deal.
I feel okay. I mean, luckily it's not something that's a common thing, a common occurrence.
This is true. The National Registry rates it as a low acuity event.
Mm-hmm.
So that
Thank
means,
God for that.
yeah, that we don't see a whole lot of it, but when we do see a whole lot of it, it can get really tough. Cody, what about you? Can you share something on any of your pediatric cardiacs?
One call in specific, and yeah, it was ran pretty smoothly. I mean, the only stress we had was the fact that you're dealing with a child, but I think it was adequate in how we handled it.
Good. Uh, Brian, you got anything there? Are you still hiding behind your card? He's going to be in and out, so that's how this works. I'll ask questions and go through this. Hey, Greg, you got a chance to say something about pediatric?
I've had a couple. They've went smoothly to an extent, but there's always that one thing that you get hung up on. And it's not so much it's not so much during the call, but after the call is when it really starts to affect you and you start questioning yourself. That's something that I've dealt with.
Very, very good. It is.
I agree. I was gonna say, you know, someone came running into the ER a week ago or so and just tossed their baby at me, and I mean, I was really comfortable. I felt like I just responded. I think the way that we've been trained, I responded, went straight to them. They tossed a unresponsive baby at me. It turned out to be a seizure. Thank God it wasn't a code. But I mean, I was already going through all of the PALS, assessment and everything else. I think it's become a lot of it. I think has become second nature for a lot of us, that we just get in there and start doing it without thinking.
And that's where we're supposed to be. That's called mastery. That's where our level, and that's what this NREMT's NCCP is supposed to do, is push us toward mastery, that things just come as natural as they can. Saying that I went on pediatric runs and I felt comfortable. I felt I knew what I was doing, but boy, sometimes putting it all together, because like Jamie said, they throw it at you. You're just never ready to walk up on a 3-year-old upside down in a 5-gallon bucket. filled with water. It's just things that kind of blows your mind sometimes. I've always enjoyed going on choking baby calls and get to the house and hear crying when you come through the door. Because that means the airway is not as compromised, at least they are breathing and we can hear it. But we've all been to these infants and infants, by the way, the age on infants is anybody less than 1 year of age, according to the American Heart Association. Use two fingers in the intermammillary nipple line, or the nipple line, the line below, right, the nipples, and the compression rates are between 100 and 120. The rates are getting faster. The breaths are getting slower. I will say that again. The rate is getting faster. The breaths are getting slower. All right. So we compress at a rate which is hopefully will build up coronary perfusion pressure, and that coronary perfusion pressure takes about 5 compressions, 6 compressions to get us up to enough to perfuse the body, or at least perfuse the major organs. Now, we go. How deep do we go?
1/3.
1/3, 1/3 of the chest. In inches, sometimes people say 1.5 inches. But if you get a big baby, 1.5 inches may not be enough. You need to go 1/3. And why is it important for us to allow for complete chest recoil? Recoil. How about that, Jamie?
For a total refilling of the heart.
Right. When we relax our fingers off the chest, we cause negative pressure in the thoracic cavity, and that lets the venous blood return. Go ahead.
Venous blood return. Go ahead.
Is that Greg?
No. I'm sorry, I had it unmuted and you're just hearing my road noise.
Yeah, I was hearing that, and I thought you had something to add. Okay. All right. So when you do that, you need to let the heart refill and venous return of blood get in there, and you need to do it. And they're getting to the point where they don't want you to interrupt CPR at all. Just continue compressions. Continue compressions. When we do the ventilation rate, the Heart Association recommends that you do 30 compressions and then 2 breaths. Remember, compressions are best, and you need to keep them going. Uh, there's something called a CPR fraction, and that means that you need to be on the chest 80% of the time while doing CPR. So if you're going to intubate them, you're going to IO them, you're going to do anything to them, you need to do it quickly and get back to compressions, because compressions is keying here. How much do we ventilate these people? How about that, David, between bites?
Sorry. Let me get that down. It should be 2 every 30 compressions, but you're talking about the percentage of the bag we're squeezing?
Volume.
Volume?
Yes,
About
volume.
350 to 500 milliliters.
Which is enough to see the chest
rise.
Thank you. That was the key point we were going for there.
Oh.
We want to get chest rise. Ventilate 1 breath every, how often did you say?
Every 30 compressions.
Every 30 compressions.
Correction. I thought it was 2 every 30 on pediatrics.
It is 2
or
every
infants.
30. I was fixing to correct you, and it's 2. Right. And they're not fast breaths. They're slow breaths, and make sure that you get it in there. Now, the good news is once we get them intubated, then we can do continuous compressions, and that's even better. Now, that's the 1-year-old. Now, as we get above 1-year-old, we go into what's called the child time, and the child time is the time from 1 year above 1-year-old and until they reach puberty, growing underarm hair in different places. So the compression rate is still 100 to 120, so that does not change. Except here we're using 1 or 2 hands, the heel of 1 or 2 hands on the chest, and again you compress it 1/3 the depth, or approximately 2 inches, allowing recoil so we get venous blood return, and that allows a good cardiac output or cardiac ejection fraction that they want to keep this person going. Here again, no interruptions. Do CPR. You know, you do CPR while the defibrillator is charging. You do CPR, between everything. You even try to get your intubations with CPR going. So do what you can to keep those compressions going. Again, ventilation's 2 breaths every 30 seconds, and oftentimes the outcomes for these infants is best if it is comprised with ventilations, even though we teach lay people to do hands only CPR. And hands only CPR has brought back ROSC in some patients because it only takes a few compressions for it goes back to the old emergency days where Johnny and Roy would have somebody go down, they do 3 compressions and they're back alive. I don't think it's that dramatic, but bystander CPR plays a big part in getting these back. Okay. Now we can do 2-person CPR, and with 2-person CPR, you get to spread the joy, spread the workload around. Um, it keeps the rescuer from getting too fatigued. Uh, LaDonna, are you out there?
Yeah.
There you are. Okay. Tell me about it. Does anything change? How often do you switch out with rescuers on 2-person CPR for children?
I think it's about every 2 minutes or at least until somebody gets tired.
Every 2 minutes or till the rescuer that's doing the compressions goes, that's it, I got to take a break. Every 2 minutes. Yes, ma'am.
Oh, okay. So I was just about to say on our last code, which was earlier this week, my partner and I, it was just him and I. So, and he's the medic. So we got to get a little bit of, CPR chest compression time in.
Yeah, you will if it's just 2 of you. And if they didn't get Roscoe on the scene, when you get in the back of the truck, the guy, the paramedic, if he doesn't have the ventilator on, he's going to get a chance to do all that CPR. Now, with an infant, we can do something a little different with 2-person CPR. If you're looking at your screen, it's right there. Jamie, how big was yours? Could you do the thumb encircling method on yours that was thrown at you?
No,
Okay.
mine was she was bigger than that. So,
okay.
but I was gonna say that the 2 thumbs that used to be my favorite. But now arthritis has set in, so my thumbs aren't as nimble as they used to be.
Mine creak and pop. I get up every morning to stretch mine out. So, yes.
Yeah.
But the pediatric AHA says that 2 thumbs encircling is probably one of the better techniques for getting a good ejection fraction if you let the chest fully recoil. Here again, it's 100 to 120 compressions, third of the posterior anterior chest. So you press down a third, allow the recoil. You know why that is. Minimize interruptions. Here again, why is it so important that we minimize interruptions? And most of you guys here have been here a long time and doing this. Have you run codes where they go, let's check that pulse? Well, what is that monitor showing? Is there a pulse with that? What did we give last time? And nobody is doing CPR. We got to remember, for good advanced life support, we have to have good basic life support. Okay. Now, for child that's above 1 year to puberty, 1 or 2 hands, 100 to 120, third of the chest. In fact, if you look at it, the only difference between 1-person CPR and 2-person CPR is in the child, and that's where you give 2 breaths after 15 compressions. Right there. All right. So go ahead. Somebody's going to pop it in there.
No, that's just clearing my throat.
Okay. All right.
Sorry.
No problem. So let's talk about the ALS, pediatric cardiac arrest. LaDonna, hang on. This will be a little bit. Maybe one of these days something will work. How about bag valve mask? Do you bag these kids or do you do mouth to mouth on them?
I ain't doing no mouth to mouth.
Not unless they're my grandkids. I might do it with my grandkids, but we need a mask. And remember that if we're going to use a BVM, you might as well give them all of the oxygen. You can help them with that. Even though oxygen has gotten into releasing free radicals, free radicals damage these cells, and that's a whole different story altogether. But they do suggest that you have high flow oxygen attached to your bag. 2 breaths every 30 compression on one rescuer, 2 breaths every 15 compressions on a child, not on the infant. On the infant, it's still 2 every 30. All right. Bag valve mask, if it works, you get adequate chest rise. You're looking at your end-tidal CO2 and you're getting adequate numbers. That means your compressions are good. That means you're oxygenating, you're moving blood around. That's awesome. That may be all you need to do. But if you can't secure the airway, you feel like it is really necessary, the next thing to do is go to your endotracheal tube or a supraglottic device. All right. Um, Supraglottic devices right now are not allowed for basics, but maybe one of these days we can get that changed. Um, Little babies, little kids, when we use an endotracheal tube, guys, it doesn't have a cuff on it. Anybody remember why?
Damages the vocal cords.
Okay. I hear crickets.
Notes
Oh.
is reversing that.
Do what's that, Brian? I'm sorry.
AHA is reversing that now on the new PALS.
About cuff tubes?
Cuff tubes. They are now saying there's no reason to not have a cuff tube on your pediatric and infant deals. Used to be because it would push them back out. If you inflated it because of the cone shaped of the airway tract, it would displace the tube.
The narrowest place on an adult is at the vocal cords. The narrowest place for a pediatric is the cricoid membrane. And Brian is right. It is funnel shaped there. So it's important for us to get it to the right place. Hang on. I thought I had somebody else wanting back in. Nope, that's it. All right. So thank you. Compressions are changed once you get a advanced airway in. And advanced airway can be endotracheal, King, LMA, supraglottic, any of those. You do not stop for breaths. It's 1 breath every
Somebody calling him.
5 to 6 seconds.
6 seconds.
every 6 seconds. Thank you very much. I threw that question out as a pop-up.
It is on mute.
Yeah, so there you go. So do
Hello?
not stop CPR. Just keep it going and going and going. All right, with the advanced airway.
Yeah, I'm kind of busy. Can I call you back? I know it's
Sure.
about a prescription you need to pick up.
Supraglottic airway. All right, for pediatrics. Tell me what you know about the King.
Bye-bye. Walgreens.
I always tell them I love you before I hang up.
That was Walgreens. Want me to come pick up my pills?
I went to Walgreens and they closed the drive-through, said come in, and I said this is it. I'll see you later. I went and transferred them somewhere else. I'm not coming in getting in any of that stuff. So King Airway. All right. King Airway for pediatrics.
It's a supraglottic device. It's supposed to be pretty simple, but they can still end up being pretty difficult depending on how the airway for the bead is. I've seen, as long as you have your lines up right, you should get good oxygenation, but they do have a tendency to fail. Not as often as they used to, but
Okay, very good. Here is y'all seeing this EMS world on your screen? Yes, no, yes.
Yes.
Pre-hospital. This is a great article about pediatric airway, and as you can see, it shows the King, it shows the LMA, and it talks about these here, and it says right there that placement 3.7 times a year. EMS found that providers only attempt pediatric IV placement 3.7 times out of the year, and intubation was only attempted once every 3 years. So that means that we need to practice our skills on this, and that's where we get into that when we're dealing with um, dealing with recertification and making sure that we're ready to go, and that's part of it. And that was from January 2009, where they went in and did the research and looked at some of these studies that talked about how our skills can degrade. So we need to stay up on those things, because if we only do it once every 3 years, are we really proficient? And if you do it to the point where you do it at PALS classes, and maybe you do it in the ACLS classes, you you need to make sure that you are getting all the skill and all the times you can get in practice times in. So there is the King.
Okay,
There
is
is.
it,
Go ahead, ma'am.
but is there any update on those numbers? I mean, surely those numbers from 11 years ago can't be what, you know, consistent now.
I haven't
I mean,
seen it.
I would like to see if the, you know, what the numbers are now, or, you know, I mean, have we stayed that the same? Are those stats the same 11 years later?
That would be a good question. I haven't seen any research on that, but their research was basically why the National Registry went to this NCCP, was so you would be able to practice those skills and in additional times to make sure that you are very proficient, because you know uh, it's not so much putting the tube in. It is kind of, but it's more important to know if the tube didn't go in. So you got to know if you don't get the chest rise, you don't get change in capnography. You need to verify your tube in a lot of different ways. iGel is another one out there that can be used for a supraglottic airway. Now, capnography. Do you use it? Do you not use it?
You're definitely going to use it. I mean, waveform is
Use it.
waveform. It doesn't matter if it's an adult or a child.
Waveform capnography is admissible as a verifying that the tube is in place. Waveform capnography is going to tell you a lot of things. Waveform capnography correlates to um, the CO2, the PaCO2 of a blood gas. So we don't do blood gases out in the field, but we can put on capnography and get the number, and the number should be somewhere between 35 and 45 torr, 35, 45 millimeters of mercury. If the person is perfusing correctly. If they've got problems, if they've got issues, if they've got cardiac output drop, then it may be going down. Um, if you put it on and they are above 45 millimeters, then we need to make sure that there's adequate ventilation rate and volume. Are we bagging them deep enough? Are we bagging them at the right rate? Then, if you get to the 15 and 35, and this is what you see commonly with patients that are in CPR, it's the low output, and that's why our coronary perfusion pressure has to be met, because that keeps this number here between that 15 and 35. But the problem comes in when we're doing CPR and we're getting a reading of 10 or less. That means somebody is not pushing hard enough. Somebody is not pushing deep enough. Someone is not pushing too fast or too slow. If it's less than 15, then we really need to be concentrating on the chest. How are they doing? And we need to make sure that they're not receiving excessive ventilations. If you blow too much air into the chest, here again, it's the same concept as leaving your hand on the chest and riding the chest and not letting the chest fully expand. Remember, the chest expanding fills the coronary arteries and fills the heart with blood. So if you've got this lungs that are squeezing the heart and you've got the person pushing on the chest squeezing the heart, your cardiac ejection fraction just goes to nothing. And that's when we're going to see those 15 and 10. Now, they are using this, and I believe I read that somewhere or watched it somewhere in American Heart Association. You get less than 10, and you've done good CPR for a while, and you're still less than 10. That is indications that maybe the code should be called, that you are not getting this patient back. They have been gone for too long. Now, that said, I know there's anecdotal stories out there where somebody has survived 30, 40 minutes of CPR and then came back. So, but with less than 10, focus on the chest compressions and then focus on, are they squeezing too much air? It's just to get the chest to move. That's all we want to do for that. All right. Um, the good news is if you're doing CPR and you're running there 10 to 15, maybe 10 to 30, and then all of a sudden it spikes, is that good news or bad news?
Usually good.
Yeah, because probably you have a thing called return of spontaneous circulation, or ROSC, and that would definitely be a good thing in this situation. Um, you got to remember though, and this is something that's really put out. If you give epinephrine, it may mess with your end-tidal CO2 values for 1 to 2 minutes. It may actually decrease that pulmonary flow and it may drop down. So you give epinephrine and it drops down. Don't jump on the compressor because they're probably doing okay. It's probably the epinephrine doing its pharmacological intervention stuff. Okay. Comments, questions on capnography? I'd like to hear some from you.
Well, my biggest thing, I don't know, capnography is good, but I don't view it as an end all. I got to be honest with you. I'm still about tube placement and effective CPR, and that's, to me, it's a nicety, not a necessity.
Yeah, but if you put that tube in, it indicates whether or not you got it in the right spot. It is,
Exactly.
it's one of those things that's going to save your derriere if
But
you get into, yeah, if you get called into court, because all you do is say, here's my capnography, and you see that it's between 35 and 45 or 10 and 15, and we're doing good. It even is maybe coming back to the fact as lawyers pick up on the fact that we're using capnography. They may even look at it and say, well, it's less than 10, so you wasn't doing adequate CPR. So it may be a two-edged sword there, David.
yeah, you're right.
Jamie, do you have something to add on capnography? She's shaking her head no. LaDonna, are you working with any of the paramedics that are putting on capnography?
Yeah, actually, my partner Zach, he's really big on capnography.
The newer guys are us folks that are longer in the tooth. Greg, David, Jamie, you're not so long with the tooth, but some of us that are long in the tooth, yeah, we kind of go.
I'm long enough in the tooth, and it's one of those things that wasn't the norm when I started. So,
Right.
And again, I think it needs to become one of those things that is second nature.
True. And David, we'll be praying that you get better at that. Okay.
Well, I appreciate it.
Yeah.
I've gotten to the point where I try to put, even with the CO2 capnography, or the nasal cannula with capnography, if I suspect like sepsis and stuff like that, I'll throw that on them just to get some kind of an idea. Is it true waveform? Is it as accurate as what you get with the tube? No, but it is still give you an idea. So.
Yeah. And it can help you determine whether it's congestive heart or if it's asthma. I mean, it will do that for you, even with the thing underneath the nose, the nasal cannula one. Okay. So, vascular access. Limit the time spent on getting those vascular access. And the National Registry's thing that was written here says IO. I'm seeing with pals that they're going away from IO some. So, David, you were saying something about that.
Say IO is always usually first on them, especially the infants. But
Yeah, I mean, you very seldom see a bone marrow collapse. If you do, they probably an IO won't help them. But IOs are rapid and safe, and all fluids can go through them. But
all
IVs,
medications.
yeah, all medications. IVs is difficult, especially in critically ill patients. I'm
Casey,
Yes, go ahead. Who's that?
I was on a 911 call. I just want to make sure you didn't try to get hold of me.
Okay, tell me what you know about IOs.
Well, from a basic standpoint,
Yeah,
I know it's just a quick access for IVs for a code, so you're spending less time trying to establish that in that sense.
right. Now, where can we put in IOs at?
Uh, the leg, and we just talked the other day. I think Ladonna was. I don't know if Ladonna was there with her partner on the shoulder. You turn the arm a certain way, and I guess it's something about it gets fluid quicker to them, or it's more efficient in that location.
It's
Good.
because it's closer to the heart, right?
Sounds good to me. I'll, are y'all seeing the protocol over here? Yes, no?
I am.
You are
Yes.
good. Okay. I was looking for IO. There it is. IO insertion. And select the IO and then put it in, and you can give some lidocaine with it. Monitor the site. That's it. So we do have a procedure on doing the IO in the protocol. That's
Yeah,
it.
if you're working a coach situation though, I don't think you need to push the lidocaine
No,
unless they're in BFib.
no, no,
BK.
no. Yeah, the lidocaine is for patient comfort. If they're in cardiac arrest, they've got they're about as comfortable as they can get. They won't feel much pain.
Now,
Very
in our
true.
protocol, are we allowed to do humeral IOs on pediatrics, or is it just tibial?
Right now it's just tibial, I
Just
think.
tibial.
Yeah, but humeral may be coming.
Hey, wait.
Okay. And of course, some of the things you think about with IO, if they have osteoimperfecta, um, don't do that with those because they got brittle bones. Um, so do it. There you go. Put it in if you need to do it. All right, back to, whoop, that ain't what I wanted. This one. There we go. All right. Um, how about dealing with drugs with pediatrics? Y'all got all these dosages memorized?
Tape.
Negative. That's what a Broslow tape's for.
That's what
That's right.
that's what the National Registry. They don't say Broslow tape on the National Registry uh, outline here. It says length-based resuscitation device. Just in case somebody comes out and makes another type of device. The length device, let's just say it, the Broslow tape is awesome. You put it on, yeah, you measure it out and use it. They have a PD wheel that you can also use. Go ahead, Greg. I think that is.
I was I'm a firm believer in the Broslow tape. I mean, it takes basically all of your thinking out of it, so you can just do what you got to do in that code situation, where you're not trying to figure out how much does this weigh? Is this the weight-based drug? 0.3 milligram, 0.03 milligrams per kilogram. how much am I going to give? That tells you right there what you got, and you're good to go.
Yeah, we can't memorize all those dosages. And a very wise old PALS instructor uh, once told me, looked me right in the eye, and he says, Casey, don't screw it up, look it up.
Right.
So there you go. If the Brazlo tape or the length-based resuscitation device is laid out there, and you measure from the head down here, and you know what you got to give, your stuff is right there. You still got to calculate the dosages. Now, are any of you people doing the uh, holding up your drugs and going, this is 1 milligram of epinephrine? Do you confirm? And there are some places that are doing that to make sure that we don't slip up and give the wrong medication. Uh, that's from the airline industry. Anyway, um, you know, some
Did you
people.
freeze up? Oh, there you go.
No, I didn't freeze up. I was trying to understand more accurate than provider estimates without a support tool. Yeah, don't guess. Look it up. I mean, we're in a world now that at the fingertips you can look stuff up, and you can always have your partner look stuff up while you're looking very suave and debonair doing your resuscitation attempt. You know, these link devices have just about everything you need. It's just the stuff that's out there in left field. You may need to contact med control for, and that's what they get the big bucks about. um, there are sometimes in cardiac arrest events, you get down so far into it, and then you get to wondering, okay, there's got to be something here I can treat. And we lovingly call those what?
H's and
T's and
T's.
T's.
Yeah, H's and T's.
Oh yeah.
Don't you love them? So let's kind of look at them. The, Before there was H's and T's, uh, the doctor that I took my PALS course from, he just said, you just need to remember the T's. And I said, what's that? He said, twins, turds, and tubals. And I went, what? So that was trying to, he was coming up with H and T's on his own. So the H's, hypoventilation. Can we fix that?
Yes.
Yes. Can basics fix that, LaDonna, if they're hypoventilated?
Yes, we can.
Yes, we can. We can fix it. Yes, we can. And hypoxia, another one we can what? Do something about. This one right here, hydrogen ion, it's fixable because if we're giving good ventilations, we're going to be blowing off that carbon dioxide, and you've all seen the little formula and how it works out there. All right. How about hyper or hypokalemia? Fixable or not?
Hey,
You can
Casey,
alter it some.
Sorry, what?
Casey, on the acidosis one, would you also give some biocarb?
There is some people that do give bicarb, and it has to be up to the condition of the patient. If it's a respiratory, like a drowning or something like that, bicarb might be indicated because that's a more of a hypoventilation hypoxia event. So, but bicarb sometimes can shift the blood, and you can correct the pH in the blood. And if you correct the pH in the blood, it doesn't pick up oxygen there as well. So you can correct the acidosis in the bloodstream and cause a paradoxical acidosis in the cells. Does that make sense?
Yep, thank you.
Very good question. Very good questions. What back to hyperkalemia? Can't we give calcium?
Yes, but
But go on.
you can change it better with some sort of IV fluids too, like a normal saline. You
Yeah,
can kind of do a little bit.
we can. We can. Uh, we don't want to get into doing calcium without we have an iStat or something that we can measure calcium levels in the blood. So that one's kind of out there. How about this one? Hypothermia. That's a good H because here we are at
Because
hypothermia.
here we are. Warm them up.
Warm them up. Warm them up. Turn the heater on in the truck. Get it in there. You get to sweating. They probably are getting just about warm. Some places use bear huggers, warm towels, hot packs to the axilla, to the groin area. And one way you can tell if they got hypothermia, you take your hand and put it on their abdomen. If you put your hand on their belly and their belly's cold, they are getting close to hypothermic. So, yeah, we can treat that one. How about hypo or hyperglycemia?
Definitely do something about that.
The hypoglycemia we can because
Well,
we
yeah.
can give them sugar. Hyper,
Hyper.
got to have a little insulin there. So, but you can always remember the thing that Brian Unruh taught me. He said the solution for pollution is dilution.
It's dilution.
That's right. So we can give them fluids, and that will bring their blood glucose down. All right. Now the T's on the other side. T's. Let's talk about those toxins. Can we do anything about toxins?
Some.
Yeah. If it's a
Depending on the toxin, I mean,
Narcan.
yes, depending on the toxin, you can do Narcan, and that may help it. And if you get a code in a young person, you may be thinking toxins. There may be something there, uh, you know. But toxins, we can correct some of those. How about cardiac tamponade? Get that long needle out and
I've always wanted to do a pericardial centesis.
yep. And that's that's the reason they took out those epinephrine needles, Brian.
Big long epinephrine. I was gonna say.
Yeah.
Hey, look, you go in at the xiphoid process, a mid-clavicular, how bad can it be?
If you miss, it can be really bad. It could be a terminal end to a terminal event. Yeah, but tamponade basically you just got to get the dose of diesel for and get them in. You can always be helpful in telling the telling the telling the doc what you think it is. And this is blunt force trauma to the chest. All right, tension pneumothorax. What do you feed that dog? Beans?
Stop.
pneumo you can fix with needle decompression.
Needle decompression. Yep. And if they've had enough trauma to cause a tension pneumothorax, they can have bilateral tension pneumothoraces. So you may wind up doing one on both sides. And what happens if you put a needle in and it's not a tension pneumothorax? You've created an open pneumothorax. And how do you treat that? You put a tegaderm over it or put something over it that would seal it. So
it's appropriate to apologize. Oh, I'm sorry.
It is, but here again, if you hit it and you let the air out, if it was a tension pneumothorax, we're talking life saving. I mean, these people are just circling the drain. I mean, they're so close to the drain they can feel it. They may even be seeing the lights and they're headed toward the lights. You can take that needle, put it in there, and I have seen these folks wake up, pressure's improved. They just get all kinds of cognitive abilities, and yeah, it works great. Thrombosis, and we're talking about coronary thrombosis or pulmonary thrombosis. No.
Not a lot we can do on that.
Yeah, just that's a dose of diesel again. Get it in there and get them on down the road. And trauma. They used to be statistics on trauma, cardiac arrest at trauma events, and they used to say that's just like 0.01% coming back. But we still got to give it our best efforts. We just can't look at trauma and go, yeah, unless the wound is so bad that you can't. They're not, if their head's over there and their body's over there, kind of separated, that won't work. They can have wounds that are.
If you have to walk to different parts of the scene to do compressions and ventilations, you don't have to do that. You can call it.
That's probably a callable one. Yep. Okay. So when we're thinking about the H's and T's, I've seen these things actually typed out, laminated, and put in the back of the ambulance just to kind of give you a heads up. I haven't seen anybody yet tattoo it on their body, but I mean, that could be a thing they could do. With the toxins, drug overdoses here, we think about pediatrics because drugs they can get in the grandma's purse and get medications and things like that. So toxins need to be in the back of our mind as we think about those things. Um, and then Narcan may work on some and it won't work on others. So hypertrophic cardiomyopathy, better known as HOCM. HOCM is when the heart muscle becomes thick, and these people are doing just fine. They're doing wonderful. And then young patients, then they suddenly collapse with cardiac arrest. And half of those that in cardiac arrest due to HOCM occur immediately after physical activity. So if you get a call down to the gym, high school gym, out to the football field, and you've got a cardiac arrest event going on, in the back of your mind, you need to be thinking HOCM. There's not anything you're going to do about it differently, but you just need to think that that could be the cause, and that's not an H, and that's not a T. Well, it is a T, H, isn't it? It's just a long H. And there's also those that have shortened PR intervals. They will also get into cardiac arrest. Komodo cordis, that's a cardiac arrest secondary to blunt trauma. That's where you get a baseball in the chest and it hits right at the right time on the R&T. And these will be in young, healthy people too. So if you get a young, healthy person that goes down and you find out they got hit in the chest, maybe they were fighting somebody, got hit in the chest with a baseball bat. I've done that, worked that one, and it can be quite scary. But that's what you'd call it is that right? Comato cordis? See that right there, David? Am I hitting that the right way? I see the dog. Yeah, he's cute. Okay.
Yeah, he wants to make sure he's in the scene too.
Oh yeah.
Damn dog.
And the last thing we're going to talk about is long QT, and that's channel myopathy, and it may be undiagnosed, and those lead to sudden cardiac arrest. Also, the shortened PR, which is along the same line as that channelopathy things there. All right. That brings me up to 8:56, which is the end of our first hour here. We'll be coming back in just a minute. We're going to take a little break, then we'll come back. If you want to go get coffee, that's fine. You want to play with the dog, that's fine. Brian, if you want to go do something objectively, that's fine. LaDonna, you can go somewhere. Everybody just take a break. I think we hit everything here: ALS management, airway, vascular access, pharmacology, and we did look at some unique cases. And those are always kind of interesting. So, all right, there we go.
When do you want us back, Casey?
Let's be back. I got 8:57. Why don't we come back about 9:05? Is that okay? 9:05 with everybody? Good deal. Screen clapping. Wow, who was that?
That was me coming through Gasville, and this fire truck go past me.
Oh, okay. I thought for a minute, boy, somebody's taking
That's
this
my
real
beast.
serious.
Come here, boy.
bunch of old
He's
fire,
just huge.
bunch of old fire horses here. We was ready to jump.
Ah, okay. Damn dogs. Yeah, we're on. Fix to go back to mute, honey. My wife's like, go to mute.
Go to mute.
Casey, how you been doing, man?
Retirement is good for me. I have been staying out of this COVID stuff. I have not been hardly anywhere except to Walmart, and they put it in the back of the truck. And I went to church twice since February. And both times I went in and they were not wearing the mask. They were not social distancing. They were not doing what CDC says. So I came home. I'm doing Zoom. I'm doing stream. I've got family Christmas this weekend where all my Jones family is going to get online and we're going to sing Christmas carols together. Yay. But, but
I've had one COVID scare so far, where I went and got my brain tickled at the one place. I've lost all sense of taste for 4 days. Um,
and you didn't
had
test positive?
low grade fever, sudden onset, non productive cough. Uh, I everybody swore that I was positive. I quarantined, and 4 days later, I test came back negative.
Really?
So
Was it the nose test or the antigen test?
the nose test.
Yeah. Uh,
They stick it up your nose, tickle your brain, and twist it for a little bit.
yeah. Is that one very accurate?
Um, the PRC test is more accurate than the rapid test. Um, where they're having the most inaccuracies is when it gives you a negative and you're actually positive. If it tells you you're positive, that's got like a 97, 98% accuracy rate for being positive.
Yeah.
But you have a less of a chance of actually being negative and being positive, being really positive.
Recorder has started, so no more LSU jokes. Okay. So this is special healthcare needs. We are seeing people now going home with more sick. People used to stay in the hospital, they got well, but we don't see that now because they get them out as quick as they can. And there are special people out there with special needs. Uh, and we may walk into the middle of some of that stuff. Uh, had to run not too long back where they had a ventilator involved, and you know they're going home sicker. We used to have a little girl at Jonesboro that we would go out. She's 6 years old, had been in a car wreck, broke her neck, and she was on a ventilator, and uh, she was surviving quite well on her ventilator. But she would need to go for checkups and things of that nature, and we would have to go pick her up. And of course, you walk in there, and then you want to unhook it and put her on a bag. She did not like bagging. She did not like you to bag. She wanted to be left on her ventilator. So we learned how to pick that thing up and move it all together. And that's what special healthcare needs is about. It may be physical limitations, it may be mental limitations, and you have lots of those mental transfers that you get involved with. They may have heightened or decreased sensitivity. They may be blind, deaf, mute, and you may have to ask certain things in different ways. And you may have behavioral and emotional impairment along with that. So, a person with a disability or a person with special needs may look just totally normal, and then they may not. So we've got to size those things up, and we have a little bit of a learning curve when we get in there if we don't know that they're a special needs patient. Brian, you want to say something? You look like you're wanting to chime in here. No? Okay. Well, feel free to. You're not going to hurt my feelings. None. Um, so, um, LaDonna, you back?
Yep, I'm back.
Okay. Have you dealt with any of these special needs patients?
Well, not specifically, but I haven't had as many years of experience as a lot of other people have.
Peg tubes, Foley catheters. Those are special needs.
Okay, the Foley catheters. Yeah, we've had. I've had some clinical time with Foley catheters. Yes, sorry.
that's kind of what this is about. Greg, did you say something? Want to have something to say?
Yeah, my son was born with special needs, hydrocephalus. Ended up getting sent home on a DSAT, D-cell monitor to measure his, and he would go apneic, uh, and just basically the size of his head caused him to be special needs, special considerations when trying to move him. Uh, Shortly after we got him home, he went completely apneic and had to be flown back to Children's after a week of being home. Even kids who are born like with that are born premature, for a time being, they're still considered a special needs patient just because of the prematurity.
Because that brings in a whole host of medical issues that can go into place in those. So, when we're looking at special needs, what are special needs? Well, as I've said, there are people out there that need health interventions, use of devices. Uh, my mind goes back to my father-in-law who died with ALS, Lou Gehrig's. In his latter stages, he had a trachea and he had a suction, and it was strange to see my father-in-law attempt to do suctioning on his trachea, uh, and he had to adapt, and these things are adaptations. Another thing we think about special needs, and that may be animals. you know uh, they may have some sort of an animal that they use, maybe a diabetic animal or a seizure animal, and what are you going to do with those? You going to put them in the back of the truck and take them? Well, would I wear glasses. Would you take my glasses in the ambulance when we went? I hope you would, because that's part of me. Um, Somebody with an amputee, you want to take their leg. A wheelchair patient, you want to take. Those are adaptive agents and adaptive equipment that they use to make their life work. I also use a cane, uh, and I've been using. A good friend of mine that was a paramedic in Alaska gave me a bear stick, and I've been using that to walk with, and I'll give you more about that later. So, mental limitations, physical limitations, heightened or decreased attributes of those. They may be cognitive. They may be congenital. Congenital means what? From birth. All right. They may be developmental. They may have had a accident that has caused their cognitive ability to be decreased, or they may have had an accident that happened. It was developmental. It could be disease related, uh, can be from trauma, and even environmental related. Um, look at this right here. This is HRSA statistics. That's 15.1% of the children under the age of 18 are considered special health care needs. 15%. That high percentage means we're going to come upon these kids, and we're going to come upon these uh, people that have this. So we need to look at that. And that extrapolates out to be about 11.2 million people that have special needs. And 23% of the households have one child with at least special health needs. So about a quarter of the kids out there are going to have some kind of special needs, and we're going to have to be ready to handle those and see those. So, what do you worry about with kids with special needs and adults with special needs? The same thing you worry about with every patient you touch. They got to have what? Airway, breathing, circulation. They don't have the three big ones. You know, we're not going to help them. So make sure their airway's open. Make sure that they're breathing. By the way, we didn't mention that a while ago in the pediatric section. And LaDonna, this may be for you, or this may be for dispatch. Um, Paul, I think it is. Uh, the kids, how do we position a pediatric, especially an infant, to ventilate them? Not a trick question.
Um, is it in the sniffing position or no?
You're right, sniffing position. How do I get them in a sniffing position, LaDonna? It's real easy. It
You,
has to do with towels. Where
oh, sorry. You put a towel underneath their neck or their
two,
shoulders.
two thumbs up. That's it. Absolutely. And the reason for that is because their head is so big. And if you lay them flat, it flexes their head forward. Well, if you flex their head forward, you constrict their airway. So we don't want that to happen. So there you go. If they've got special needs, it's probably best to involve the caregivers. I know sometimes we don't like to have home health nurses on the scene when we get there because they want to tell us everything. But really and truly, if the home health nurse has been taking care of this patient for an extended time period, she probably knows the patient better than we'll ever know the patient. So we need to listen to these folks. We need to listen to the caregivers. We need to listen to the parents. Greg, when they sent you home from Children's with that machine, did they teach you how to use it? Guess he went down to one of the valleys over there in north central Arkansas. The answer is yes, they will teach you, and so the parent becomes the. Go ahead.
Sorry, Casey, were you asking me a question? I lost service there for a minute.
I thought that's what had happened to you. I said when they sent your child home from the children's hospital on the machine, did they teach you how to use it?
Oh, absolutely. They made sure we knew how to use it and were comfortable with it before they even let us consider leaving.
Yeah, and that's very true. That's what we were saying here, that we needed to make sure uh, that we use the family as much as we can because they become the experts for that. Medical history, ask the parents about medical history. Just don't put, David, on your medical history of your patient history on your PCR unknown or unable to obtain. You always can get some history from somebody. I mean, it might take a little bit of detective work. I'm not picking on you, David, by the way. You just happen to be the one I looked at up there. But but spend some time getting your medical history. And where can we get that, Cody? Where do we get medical history from?
Caregivers. I always thought, if you look around for maybe some medications, it might kind of give you somewhat of an idea.
Two thumbs up. Good way to do it. And I hate reading charts on transfers from hospital to hospital, and I have history unable to obtain, or it's in the chart. I don't know if you read the history or not, so you need to document that. There we go. Is the patient acting appropriately? You have been with this patient 4 or 5 seconds, maybe a minute, and the thing in your mind is this a change? And who's going to know if it's a change?
The caregiver.
The caregiver.
Anybody,
The caregiver.
anybody who knows him, actually,
Yeah.
doesn't necessarily have to be a caregiver.
True. You can ask the crowd, is this normal for him? If he's at a school function, is this normal for him? And then we need to get one baseline vital sign. We need to get that right off the bat. And our protocol says we get a baseline vital sign when we contact the patient, and we get at least one more vital sign before we release patient's care. So you got to have two vital signs, or that's a protocol error, and we want to make sure we do that. Uh, Medications, get their medications. Cody was right. Look at their medications. That will give you a hint. If you're looking at medications and maybe they've got Lasix and Lanoxin, and yeah, that give you an idea what's going on with them. If they had phenobarbital, or if they had, you know, some kind of a mood depressor, and a
Or
lot of
digoxin.
digoxin, you betcha. Caregivers a lot of times have a go bag. Uh, Not only caregivers have go bags, people that have special consideration needs have go bags or rescue kit, something that they would go to if the unexpected happens. Where would they get that? And it may just be simple stuff just to meet their needs.
Like a suitcase and their phone charger and their phone.
That may be it. You betcha. Uh, or it may be their charger for their LVAD. That's something that can be done. Uh, Try to be calm when you get to these patients because they've been in the healthcare field long enough to know if my guy that comes in to my room is freaking out or a little bit excited or making me worry, that's not going to be good for the outcome of the situation. So slowly, quietly, calmly, go about your business, making sure the airway's open, that they are breathing, they've got circulation. Once you get that done, then let's find out about the specialized equipment that they're on, or get their medical history and go from there. Um, you know, uh, Make sure that you bring the caregiver with you, especially if there's a special device that they know how to run. The lady that I was telling you about, the little 5-year-old that broke her neck and was on a ventilator. Every time we took her, we put Mama in the back seat so she could be right there next to that ventilator. Because when that thing started making alarm sounds, uh, yeah, I got uncomfortable, and Mama would go, "Oh, it's just this." She just fix it, and I more or less was just providing transportation at that time, and that was okay by me. Um, Take time to explain your actions. They want to know what's going on. If this was a ventilator and it was breathing for you, and this little girl had been told by the hospital, um, a children's hospital, not that Arkansas Children's Hospital, that if this ventilator quit working, she would die. And that's why she got real apprehensive when you had to unhook her from the ventilator to move her to the cot and start using your bag until we got the ventilator loaded. Now, this is, you got to think about this. This was when ventilators were the size of little mini refrigerators. I mean, this is not anything new. So, some other things we need to think about with special needs patients, because they've been in the hospital quite a bit, and y'all get this question asked to you every year in October by our friends in education. What do we need to worry about these people? Go on, David.
Good old latex allergy.
Latex allergy, and what vegetable or fruit are they? If they are allergic to this fruit, then they'll be allergic to this. What was that? That was question.
Bananas.
Bananas.
And
We all remember that question. Yeah, on the thing. But yeah, especially in spina bifida patients. That's just because they've used latex and they've developed that. Some of these kids have developmental problems. They only mature to a certain age, and then that's it. They may have hearing or vision problems, and hearing problems. If they can't hear you, you know, uh, then you may have to have just a little bit of sign, you know, and knowing that, that's something that you might want to do. You got 10 hours, 15 hours of professional development that goes on the end of this class, and that will take care of that if you want to take a class in that. Um, don't leave their hearing aids behind. Don't leave their glasses behind. Ask all that stuff. If you got a geriatric patient, this is a special needs patient that we sometimes forget is special needs. Dentures, you know, if you're going to take them into the hospital, they're going to eat hospital food for a while. They're going to need their dentures. Pum pum.
Well, and those people are extremely self-conscious about, especially women, about having their dentures with them. So, I mean, I realize in the middle of a code, maybe it's not that big of a deal, but you don't really want to buy a $1,500 set of dentures because you lost them and they really want them. If you happen to let them survive, or if they're not dying, they're going to want them in a little bit.
And they used to teach, and I don't understand why, that you would take the dentures, hold them in your glove, and then strip your glove back, and they'd be in the dentures. Well, that works good, but what happens to used gloves after you're through with the run? Trash can.
yep.
So that was a good idea that probably went bad. So there you go. We're talking about
Hey,
special.
can
Yes,
I say something?
you sure can.
On the special needs patients, and most people probably know, do realize that even though, and you're 100% right, I agree with you, 10,000%, the family knows those devices and those things so much more than we do. But do understand, if they're calling us in the pre-hospital world, it has gotten out of their control. They're nervous and they're upset, so don't throw it all back on them. Realize they're calling you for some help. And even though they're the technical experts, this has probably gotten above their head, or else they wouldn't have given us a shout.
And that's why it's so important for us to remember, maintain airway, breathing, and circulation. We got to keep those going, and then we can work on the other problems.
And just like a
You
stroker,
know,
don't necessarily consider these people that are slow or have a hard time to responding that their intelligence is low. Dealt with a guy a lot who had been involved in massive trauma, and he was nigh on to genius level, but he was unfortunately locked inside his own brain. Trying to say normal words caused him the greatest frustration in the world. You could see he knew what he wanted to say, but for some reason he had a block of trying to be able to spit it out. But he was phenomenally intelligent. It was just really, really hard for him to speak, and you would naturally want to finish his sentences, and that was extremely off-putting to him.
Very true.
It was very frustrating that he couldn't speak, and then when you spoke for him, that was even more insulting. Just be careful is all I'm saying, I guess.
Jamie?
yeah, I just wanted to say, along with these, especially like our geriatric patients and things like that, that have been during this time, during this pandemic and everything, something that seems so very, very simple, but along with the dentures and things like that, a lot of people are bringing their cell phones. Grab a charger, because we're visitor restricted at the hospital. They can't have their loved ones at their bedside, and so they need that communication, with the outside world. I mean, it's a big thing for these people to be able to communicate and keep their spirits up somehow or another, to be able to recover. And so I think that that's something that if we can start remembering, if you think that your patient's going to get admitted, bring a charger for their phone so that they have that. A lot of them, will do that. That way they can do FaceTime. I understand a lot of them will have a phone in their room, but the face-to-face is huge for some of these patients. And I think that that's something that, who would think of that? I'm starting to see that every day. And so otherwise I would have never thought of that, but it's something that's important to people.
It's good to see your face, even though you got your mask on. Yep. And I got the Christmas cheer going on here. David, moves left or right so we can see your tree. Uh-oh. There's my Freestyle Libre going off. I'll get it in a minute. There's his tree. So you're absolutely right. They need to bring their chargers because they need to communicate to the outside world, especially this time of COVID. We got in the middle of this with my mother-in-law. They had a car wreck. She had the car wreck. She was put in Baptist Hospital, Little Rock. They said one person, one visitor, one time a day. So her son went up. My wife drove from Harrison down there to be with her, and they wouldn't let her in the hospital. They said she's had her one visitor for today. So they had to wait till the next day to go in to see her. And then the other daughter couldn't get in because my wife got in and she wasn't coming out. So anyway, it was kind of an interesting situation with COVID. COVID is definitely put a lot of strain on it. Remember, just because they got a physical disability does not mean they are cognitively impaired. And that's what Brian was talking about a while ago. Who's that? Stephen Hawking? Is that the guy that was in the wheelchair that was just brilliant, but he couldn't talk because of his special needs? You might need to ask them what hospital they want to go to, and they may want, if they've got a lot of significant special needs, they may be going to a special needs hospital. For example, an LVAD might want to go back to Tulsa where they had it put in. You may have a children's child here that needs to go to children's. So they're going to want to go where they have received their care. So what are we going to look at? What kind of common equipment are we going to run into? And I like this. I already talked about the stoma, the patient that has the trachea and the stoma. Go ahead.
What we're seeing pretty regularly is those magnetic things for like seizure patients and things like that. That's a pretty frequent special
Yes.
need.
Yes.
And I mean, it's not something that's visible; it's on their person. So I mean, you need to think about those things.
All right, Greg.
You see, in the elderly or people my age and older, you start seeing people with trilogy machines. That needs to go with them because the hospitals don't always have them to use for their BiPAP.
True. 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 And those are the things that we need to think about. Um, oxygen delivery. I mean, we have people walking around with these little miniature oxygen devices, and uh, heaven forbid that you would not want to bring one of those with them and their charger. There you go. Um, so you have cancer patients that you know go to the Claude Parish Radiation Center, and they have the indwelling ports. Those have potentials. My brother, who died last January, he had esophageal cancer. It was all throughout his alimentary canal, um, and he had gone through a bout of having a feeding tube in, and then having a ileostomy and colonostomy. So yeah, all those things you got to worry about. Um, Feeding tubes, another one. And those, if they're left in too long and not changed out properly, infections can occur. They can get occluded. The stuff that they put down them can occlude it. It can be dislodged. And I remember a little lady we used to transport all the time in Jonesboro. She had a feeding tube, and for some reason, hers would just get dislodged. And we had to finally figure out that it was her husband dislodging it when he would help her get up to go to the bathroom. So we did transport her to the ER several times on a Saturday morning for tube that needed to be replaced, and the tube can break down, and that happens too. How about cerebral spinal shunts found in hydrocephalus babies? The shunt runs underneath the skin, so you really don't see it.
Shunt runs underneath the skin.
Greg?
You'll notice you'll notice a bump behind either the right or left ear, which is where the actual shunt valve is. You have tubing that runs down along their neck over the collarbone and into the abdominal cavity where the fluid will drain and absorb back into the body. There are several different types. And when you see a malfunction in one, you'll see either rapid drainage of the shunt, or you'll see where the shunt has stopped draining, and you'll start having a patient complain of increased headaches. You'll notice they'll complain of pressure behind their eyes with the buildup of fluid, um, and that's a good indication that there is going to be a shunt revision that's going to be needed. With the advancements and stuff that they've made, they came out with the Codman Hakim electromagnetic shunt, which they were able to just like it's what my son had. Uh, they were able to just go in and adjust it and open it to where it would drain more, or close it to where it would drain less, and it didn't involve a surgery every time. So I mean, their advancements that they're making are great, but still something you need to be watched out for. Something if a patient falls and lands on that side of their head, you can expect that there's going to be a possibility of damage to that.
But kids never do fall.
Right.
Kids are kids, right?
Exactly. They bang
Okay.
their and little boys will bang their head on the floor just because it's fun to them. So
Little boys bang their heads on the floor because they know little girls are around one day, and we got to get used to getting our heads banged on the floor. Sorry, Jamie. Uh, they might want to play football. There you go. So, and they may be a good football player. Uh, Absolutely right. Common occurrences for these kids with the shunts is infection, brain infection, and those are going to see up like sepsis and things of that nature. Obstruction is going to be that intracranial pressure, pressure behind the eyes, headache, and then they can either drain into the peritoneum or into the right ventricle. I found that very to be interesting that it would drain in the right ventricle, and if it because it drains into the peritoneum, it can cause peritonitis. So that's something that might happen. Uh, Dialysis shunts. You run upon those things, they are very common out here. Uh, don't do blood pressures on that side. Don't start IVs into the fistula. Things that you don't do. Um, that's the hemodialysis. Of course, the other one is the peritoneal dialysis. And if you ever anybody run into any of those, I know Brian has. David, you have?
I have.
Pretty rare, but you do get them.
Who was that?
That's me.
Oh, that's you. Okay.
I had my father-in-law or
Uh huh.
stepfather-in-law was doing peritoneal dialysis, and then a good friend of mine from up in the Deer area, he was a diabetic. My father-in-law was a paraplegic and had some kidney issues due to the paraplegia, and then my other friend was a diabetic who was having a lot of really major issues, and he did it. He thought it was the greatest thing since soap, simply because it didn't require going to a dialysis unit and gave them at least the freedom of being home. I mean, it's still a sucky deal, but he would do his at night
Yeah.
and hook himself up on the machine and dialyze at night while he was sleeping. So it wasn't like every other day he had to go in to uh, go get dialyzed. So there's a certain amount of freedom that comes with that peritoneal dialysis. It's not all bad. I mean, it's not good if you're on dialysis. Period. It's not good, but
Very true. Um, and the peritoneal dialysis is they have a tube that goes into their abdomen. They run in 3,000 cc's of fluid. So when you get the IV bag, if you see a 3,000 cc IV bag, they're not getting IV fluids. They're just running it into their abdomen. The one I ran upon, he was involved in an accident, and we were taking his clothes off and doing that, and I run upon this 3,000 liter bag rolled up in his pants, and I was going, "What is this?" And then he explained it that he had to put it on the table beside him. He laid on the couch, just let it run out, gravity feed. Then he took it off and put another on and run it back in, and wadded it up, and that's how he did his. Um, but it is dialysis. It probably is people that are in the early stages of the kidney failure, so they can use the peritoneum to actually get out the waste stuff there. Um, Common complications for these, anybody want to guess? Peritonitis? Sure. Infection? Sure. Even with hemodialysis, you have infection. You don't have the peritonitis, but you have infection, and you can get excessive bleeding if they happen to bump that fistula and tear it open, or it can get opened up. Foley catheters, we've all seen these. They go in through the urethra up into the bladder. I like to tell the story of the fire department in a certain town south of here. Evacuated a nursing home that caught fire, and they evacuated all 30 of the patients. They were so proud they got the patients out. Then none of them were hurt. They were laying there on the ground, and the ambulance crew showed up to start transporting them, and they got to noticing none of them had Foley catheter bags. Well, when the fire department evacuated them, it was life over limb, and they left the Foley bags attached to their beds. So I'm sure that was done with a lot of trumpeting and screaming. Um, there's suprapubic catheters. Those are also infections can occur. Foley catheters, you can get kidney and little urinary infections. Go ahead, somebody.
Yes, I just wanted to say the reason why they were all laying down and such is because of those catheters being pulled out.
Yes, yes, very true. GI bags, there is a colostomy, and this is what my brother had. It diverts stool away from the colon or large intestines. This stuff can be really quite toxic, so be careful. He came to visit one time and changed out his bag in my bathroom and accidentally spilt some of it on the floor. He cleaned it up as soon as he can, but vinyl linoleum does not like stomach acid contents. It kind of colored the floor a little bit, but it's a great reminder of my brother. I wouldn't change it for anything. Um, Ileostomies, that diverts stool from the ileum into an external bag. They don't pass into large intestines. Um, I think his was an ileostomy instead of the other one. Then you can get into the cognitive impairments. You know, human. We have the Boone County Special uh, special needs folks, special needs Boone County. It's out here on Industrial Road. They do work out there, and then they have certain little places around where they live.
You
Uh,
mean independent living,
Independent living, yeah, but
special services,
it's Boone County Special
services?
Surfaces. That's what it is. And they will come out and they have caregivers that go with them and they can live independently. Some of them do quite well, some of them not so much. Uh, there's several of them that come to my church, and every now and then I'll get a text on my phone from Miss Rebecca, and she'll just say hi, and I'll send her back hi. That's it. That's all she wants is just a little touch, a little contact from us. Um, be aware of your actions and words and the way you move around these people. You can trigger them to get quite excited. They may look grown up, but they may not be grown up. And here again, that's where you go back with the caregiver and find out your best information from them. Um, your difficulties, when emergency happens and they are cognitively impaired, they don't seem to understand what's really going on, and they may not associate with what's happening to themselves or others. So, you know, stay calm. Remember, your patient mirrors your attitude. If you're staying calm, they'll stay calm. Um, Accommodations, walkers, wheelchairs, oxygen devices, service dogs, whatever. Bring all that stuff with you. Chargers for their phone. Remember that too. That's a great point Jamie brought out. So allow time for gathering history. They may or may not be good historians. They may have a book that they actually had one patient, special needs patients, that was living independently. We'd go see her, and she had a book. She just hand you a book. Here's my medical history, and you go, okay, that's overwhelming, but it's there.
Hey, Casey, on that
Yes,
note,
yes.
um, a lot of our chronic care patients and special needs and stuff are now patients of the community paramedics. And community paramedics will leave, we have a binder there that has med lists and they get updated when meds change. A lot of patients keep track of their weight if they're CHF patients, that kind of thing. So there's weight logs, there's vital signs logs, there's all those things within that binder. Um, PCP information. There's a lot of information in those binders, so maybe kind of look for that as well.
Now, are those left at the house, or do y'all transport them with you?
Yes.
Okay, they're left at the house.
No, the patients have the binder at their home. We keep a separate folder with that information for our records.
Thank you. So community
Mhm.
paramedics are going to impact the way we deal with special needs, and that's the way it should be, because everything that's working here, from the home health aide to the caregiver to the community paramedic to everybody, we're all wanting the patient to get the best life that they can have. And gathering a history, if it's a community paramedic book there, wow, it's done. Just got to read it and then translate it to your PCR. You need to perform an assessment and explain why you're doing assessment and how you're doing it. And if they fell down, start with a focused and get your information on what you need there, and then spread out from there to get the rest of it. Um, Patient management procedures, if you're going to start an IV, explain what you're doing. Anytime you're doing anything, if you're putting on a splint, explain what you're doing. Prepare the patient for the transport. Get them to understand what's going on. And some of the common stuff that's out there is intellectual development disorder, and this is something that happens before adulthood, and it can affect their cognitive functioning, and they'll have deficits in two or more adaptive behaviors. There is mental retardation, and that's where you get deficits associated with medical and behavioral signs and symptoms. And then there's non syndromic mental retardation, and this is where mental defects appear without other abnormalities. Um, so we don't call them mental retardations. Don't call them mental retard anymore. They're special needs patients, and that's just we want to be as politically correct as we can with these patients. Um, you don't want to say they ride the short bus. No, don't do that either. That's not cool. All right. Questions? Cody, you got anything there? Hadn't heard from Cody in a little while.
I had to switch back over. I was working a call.
That's okay. Worked your call, brother. Keep the revenue coming in. Any comments on cognitive impairments, Cody, LaDonna?
Not really. I personally have only just ran into a very small percentage of patients with special needs as far as their mental capacity.
Okay.
But a lot of Foley's and dialysis patients that we all have.
Well, that usually runs downhill with the dispatch to make those basic transports, and yeah, we understand that.
I done a lot of dialysis transfers when I worked for Pafford. A lot.
Yes. Did a lot in Jonesboro with Emerson, but we did it mostly with wheelchair. If they were wheelchair, we didn't do stretchers that much, especially after PTS and Medic One got in trouble over there. It wasn't Medic One at that time; it was something else. Keller was Keller. All right. Down syndrome. This is one of the complex mental cognitive reduced cognitive ability, and this is chromosomal. It's down there in the XY genes, and we don't want to get into that. But these folks here are intellectually developed. They do have decreased muscle tone. They'll have upward slanting eyes, small folds of skin in the corner, small shaped ears, flat facial, small nose, wide, short hands with short fingers. Known cardiac issues, see spine instability, large tongue that could complicate airway problems, thyroid issues. So they're either lots of weight, vision problems, and they are 10 to 15 times more likely to develop leukemia. Interesting fact. So, what kind of problems do you have with Down syndrome? Well,
What was that last statement, Casey?
10 to 15 times more likely to develop leukemia.
I did not know that.
I did not know that until the first time I went through this. And I looked it up, and they get their statistics out there. Greg, did you have something? I heard your car noise.
I think one of the things that will have issues or things that we run into when dealing with people Down syndrome is they have a hard time communicating what's wrong. That understands what their complaint is. We kind of just run into a situation blind where we're not able to. They can't communicate what's wrong with them, and we're not able to figure out without the assistance of somebody else.
True. And what's normal for them?
And what's normal for them?
I was fixing to sing this. I was fixing to sing that song for you, Greg. Down in the valley's so low, the signal doesn't get out, so just keep on going. We got the gist of your situation there. So problems with these folks, problems with Down syndrome, they wander off. You know, they're not focusing. They squirrel, and there they go, and they wander off. They got obsessive compulsive behavior. You be very careful about saying take their pulse. You don't take nothing from them. You measure their pulse. You measure their blood pressure. We had a little girl that we said, we're going to take your blood pressure, and she thought we were going to take her blood pressure. They are stubborn. They're obstinate. Yeah, they you can get that too. Impulsive behavior, poor judgment, short attention span, and slow learning. But yeah, that's Down syndrome. Little special needs patients, just got to love them. They're really sweet. They're really loving type folks anyway. Um, but they want to do it their way. They're some of them are almost stuck in the terrible twos, if you remember those folks. Let's talk about cerebral palsy. This is a progressive disorder that damages the central nervous system. Is that what Hawking had? Was his cerebral palsy or was his muscular dystrophy? I don't know. Okay, so where does cerebral palsy come from? Well, it happens in the womb, and it can happen during the first 2 years of life as they develop. And what happens is they get abnormal muscle tone, muscle spasms, and hearing and vision problems and seizures. So when you're looking at a pediatric patient within the first 2 years of life having seizures, eh, you may be dealing with cerebral palsy. And they may not be able to talk to you very well. But remember, it can be the causes of cerebral palsy can come from low oxygen, intrauteral low oxygen. So they have had low oxygen when they were in utero. Something happened to mama. She didn't transmit the oxygen like she should. Mother could have an infection, measles, rubella, any type of infection that can cause, they could go to cross that placental barrier into the baby and it cause cerebral palsy. Head injury. Uh, Kids are already, got big heads and they lead with their head and they fall down. And when they fall down, they are easily to get head injury. The RH factor incompatibility. Daddy's positive, mama's negative. They don't catch it. That can cause cerebral palsy. And we talked about herpes, rubella, simplex, herpes simplex in the mom. That would be that infection. And I don't know why they put infection on this thing twice, except maybe they want to stress the fact that cerebral palsy can come from others' infection, also from baby's infection too. Bring the walkers, bring the wheelchair. Don't assume cognitive disability just because they got a physical one. Brian brought that out a while ago. And then we get down to the last one here in this list of things as we get close to our next break, and that's got to assess patients with autism, autism spectrum disorder, ASD. Um, Remember, autistic patients are aware of what's going on around them, but you need to explain their actions, tell what you're going to do and how you're going to do it. Uh, Include the caregiver because that keeps them calm. And Brian's also correct in saying if they've called for EMS, they're at the end of their rope. So we need to kind of go in, be in charge, be supportive, but utilize them also in the care of of this child. Uh, no sudden movements and show your patient what you're going to do. Demonstrate on the caregiver. If you're going to measure the blood pressure, do it on the caregiver and then do it on the patient. All right. Special needs. Some common needs that we need to know about. Identify our objective. Identify common special needs patients seen in the EMS. Have we done that? I think so. Relate the role of caregivers of special needs patients to the EMS, professional EMS. We've done that. And describe the patient's assessment of a special needs patient. You want to make sure you always go back to the ABCs. That's where you need to be with these people. Brian, you have something you want to add?
Lou Gehrig's disease.
Lou Gehrig's, yes.
That's
AL.
what Stephen Hawking had.
Oh, that's what he had. Okay, well, that's what
Also known as ALS, right?
ALS. Yep, that's what my father-in-law had. My wife has early tendencies of that, and we may be seeing that in her because it is genetic.
They called it motor neuron disease known as amyotrophic lateral sclerosis or Lou Gehrig's disease.
That's it. Okay, y'all ready to take a break? I've got I got 10 o'clock. Y'all want to take about a 10-minute break? Be in about 10:10. Will that work for y'all?